thank you very much for joining me today. I think this is our fourth webinar. What we're looking at today is the shoulder. What we did, I think, 2 weeks ago, it was originally neck and shoulder. It's far too much to do in one go. So we looked primarily at the neck and ruling out cervical radiculopathies, all those problems, and then how to treat with the laser for the neck problems. This is really a continuation, and I think we need to do, what we need to do is actually look at the shoulder in a separate light, but we will be looking also considering that the neck might have an involvement with shoulder problems. And this is very much the problem with a rotator cuff tendinopathy or subacromial impingement. There are a number of other things that can go on, but really, one thing we've got to consider, what is the difference between a rotator cuff tendinopathy and a subacromial impingement? Because the two things are so interrelated, and we'll come back onto that when we've looked at everything. What we'll do then is we'll look at some areas of which can add to the pain, especially myofascial trigger points. This lovely laser has brilliant technology and a brilliant system where we can actually work on the trigger points as well. And then we'll go into actually treating a shoulder, and we'll treat it with the MPHI, the handheld piece, and we'll also use the Charlie head, the big Charlie head, and we'll see if we got time to use them both in conjunction with each other. So, without anything else to add here, can we just, sorry, I don't want to go into all the way that this laser works, but quite simply, it's a phenomenal piece of equipment because what it's simply doing, in a nutshell, it's sending in two widths of light, 808 nanometers and 905 nanometers, both which will go into up to 5 or 6 centimeters deep. They will work on pain reduction through tissue repair, through reduction of edema, through reduction of inflammation. And at the same time, the 905 nanometers is sending in 25 watts on some of the machines, even up to 75 watts on other machines, which is massive power because a class 4 laser starts at half a watt, basically. That's where it goes from. But the 905 nanometers super pulsed works on pain pathways. And so with a combination of using this and, like I've said in every webinar I've done, with a structured mobilization rehab program, then we can have incredible results. Always remember, I've always said this, this machine is no more than an adjunct, but as an adjunct, it is the most phenomenal adjunct that I've come across in my long period of doing physiotherapy. So let's get straight on to having a look at some slides sent by Acer. Just a quick apology, if there's anybody from Acer, the manufacturers here, they sent some slides. I've spent quite a while changing it from Italianizations to English, so it does roughly read okay. But apparently there's supposed to be some animations on this video, on this slides. There is no animation because I don't know how to work it, so we're not going to do that. Right, let's get straight into here and have a look at the screen. Okay. Right, here we are. Hopefully you can all see that lovely tennis lady she's got shoulder pain. Such a common thing that people get this. Right, let's have a very, very quick look at everything that's going around here. We'll have a further look at the musculature, but there is a huge amount of stuff around this shoulder, lots of different muscles. I don't know if my cursor is on there, but the middle trapezius one here This is so important for controlling this thing, your scapula. Here we have one of the rotator cuff muscles, the infraspinatus teres minor. Then there is the supraspinatus just underneath this nasty little area, and the subscap underneath on the front, on the anterior side of the shoulder blade. That does what it says on the in the tin. They are rotator cuff muscles. They rotate this shoulder. But I think what's important to actually just get in your brain straight away that a better name for that rotator cuff would be the compression cuff, because we have a phenomenal piece of equipment here. This arm will go in any direction, pretty amazing. And we first know when there's a problem, when we're having problems, we're getting pain, especially on abduction, on external rotation. Well, we can't move this shoulder, and that's telling us something's going wrong. And it can often be a problem with the compression cuff, because those muscles are the only muscles which keep a fairly large golf ball in a tiny little golf tee. And if that's sliding off or moving forward or backwards or up and down, naturally, if it goes upwards, it lowers this place under the acromion. There's all sorts of problems that can occur. So huge amounts of muscles around here. We'll go on to the next slide. Just in a different direction. Here he's gone right into internal rotation. That's something which often goes with a shoulder rotator cuff problem. But it's more external rotation, which is a big problem, and abduction. Let's move on. Right, now, when we're treating, this slide comes up very early with ACER, because we look at, if you've seen my previous webinars, when we're treating with this laser, there are two approaches. There is the global approach, and then there is the pathology approach. Global approach, if you get your little books, you'll see it talks about the scan, but we want to treat all the muscles in the surrounding area which are connected with this joint, or the muscles, the problems that we have. And then we want to treat the pathology itself. So what is very important is this idea of the optical window, especially if you've got a joint as complex as this. Whereas here they've obviously pulled the shoulder round into right across the body. And so now we're opening up the optical window. We can get in the back of this joint, okay? So when we're doing any treatments, maybe the first time or second time we treat the person, we might do it fairly passive, or just not doing any movement at all. But as soon as we can and things are easing, we need to get in with active movements while we're doing the treatment, and that will help so much with your results. So we've got to look for the optical window at all stages. Right, shoulder, there's an awful lot that can go wrong here. This is stuff, I don't need to tell you this. This is all stuff you know. Two types, the acute lesions and the chronic lesions. What are the acute ones? It's so often involved in trauma or anything like that, but fractures, dislocations, and rotator cuff lesions. I do a lot of work with rugby players. You see it so often. Fella just smashed down onto the shoulder, bashed right in there, which forces the acromion against the humeral head, which actually causes a problem on the usually the supraspinatus tendon, but it can cause a problem on the biceps brachii, or even the infraspinatus. The chronic lesions, this is where most of our patients are going to come from. Tendinopathies, calcific tendinopathies, very common thing, muscle lesions, subacromial impingement. Right, now, look, I talked before, subacromial impingement covers so many of these problems because that is such an important area. Shoulder instability, again, I talked about the rotator cuff being a compression cuff. If that rotator cuff is not working correctly to hold that golf ball in that little golf tee, then we've got instability, we've got movement around, and we can force this humeral head into all sorts of places we don't, which is going to cause problems. Bursitis, again, going back to that rugby shoulder being smashed in the ground, you get inflammation of this little bursa, the subdeltoid bursa or the subacromial bursa, biceps brachii tendinitis, and the one thing which is always a bit of a problem, and slap lesions. And I think even with a true slap lesion, the manufacturers will probably go crazy with me for saying this, but I just find slap lesions do not rehab very well. And that is the one area where we might need an orthopedic opinion. But we want to keep orthopedic opinions away from so much of this, because what they'll do is they'll go and they'll inject a corticosteroid into this area. What we're doing with this laser, we're doing tissue repair. When you stick and we're reducing inflammation, when you're sticking an injection of corticosteroid into these areas, it's a bit of a nightmare, because what you are doing is, yes, you're reducing inflammation. That might feel better for 4 or 5 weeks, but the problem is going to come back, because you cannot even repair it then, because what the corticosteroid, it actually inhibits the regeneration of the tenocytes of the tissues itself. So this is why I'm very much against, unless it's absolutely necessary, moving on for an orthopedic opinion. Right, the rotator cuff itself, let's go on here. Causes, right, well, substantial injury, of course, or progressive degeneration, more common for us, wear and tear of the tendon tissue. You'll often see it with people with doing lots of repetitive overhead activity, lifting may irritate or damage the tendon. And then a lot of that comes down to control of the scapula. So it's the muscles around that, especially the mid-trapezius muscles. They've got to be working correctly and in time to actually move that shoulder blade and control it, because if they're not, then as the arm comes up, it's just jamming up underneath that acromion. Rotator cuff tears, much more common in older people. That's a bit of a genetic problem. These things do, the whole construction of it isn't great, because they come up and they become very flat when they come on to join into the capsule. And so a nice big tendon becomes flatter and flatter, and so it takes very little damage to cause problems on there. There's a mention here, patients with knee osteoarthritis or other painful leg conditions, they can often find they get shoulder problems because they're compensating using the upper limbs in an incorrect way, which may cause shoulder damage. Not so sure about that, but it's something to consider. As I said, often there's a genetic component, and these tissues will, as we get older, will degenerate. Without retreatment, rotator cuff injuries may lead to permanent loss of motion or weakness, and may result in progressive degeneration of the shoulder joint. And that's where you might have to get the orthopedics in. With this laser, this is what we're trying to avoid. This is what we stop, okay? Inflammation of a single tendon causes pain when doing specific movements. The tendon may tear after it is weakened by inflammation. Yes, of course, anything can. So let's take away the things which are really causing damage on there. Let's move on to the next one. Here's a very clear problem in the supraspinatus, which is coming over just underneath that acromion, acromion clavicular arthrosis. Let's have a look on. Well, let's quickly go on to calcific tendinopathies and subacromial impingement. Okay, calcific tendinopathies, looking at very common condition caused by the presence of calcific deposits in the rotator cuff, and this is something which just happens as time goes on, and we get little bits of damage on there, or in the subacromial subdeltoid bursa. Calcification spreads around the tendons. In 10 to 20% of patients, calcific deposits are both sides, okay? But one side is probably asymptomatic, the other is symptomatic. So the question is treating the symptomatic side. but not forgetting the side which doesn't show any pain, because we've probably got problems in there coming up later. Most affected zones, supraspinatus tendon in 80%, infraspinatus 15%, subscap 5%. Deposits, as I said, may be asymptomatic in 20%, or just even a very low grade pain. So don't ignore these slight little signs, okay? Subacromial impingement, tendons in the rotator cuff can be injured easily due to the tight space where they move. That's that subacromial space. Bump or rub against the acromion or against a ligament at the front of the shoulder. Friction is known as impingement syndrome. It causes inflammation in the rotator cuff, which leads to pain and then further degeneration. Okay. Instability. I'm not going to spend very long on this, but instability is what we talked before about with this rotator cuff. Not having the ability to hold that golf ball in the golf tee. Very important. So, as I said there, yeah, inability to hold the head in the glandular fossa. Ligaments and muscles around the glenohumeral joint create a balanced structure. If the integrity of the structure is disrupted, this can lead to injury. So, let's get thinking all the time about working on, in rehab, on working on that rotator cuff. Bursitis, it's the inflammation of that little fluid-filled sac where the tendons run. The biceps brachii tendonitis, it can be through impingement, through subacromial impingement. It can, especially with the people who are much more winging scapula, this humeral head, and I'm going to show you in a second, will come forward and cause problems. Slut lesions, injury to the glenoid labrum, total of 4 types. Even the basic one is a bit of a problem. So let's stop the share on here. I've rushed through there. You're back in the room, but hopefully we can actually now consider the rotator cuff, okay? The sits, the supraspinatus, infraspinatus, teres minor, and subscap, the sits muscles. They blend into the capsule, as I said before, become thin and flattened. What do? Well, they aid in movement. But just understand this again. I'm saying they aid in movement. They don't do the whole movement. And again, it's actually working out how to get those muscles working, i.e., the infraspinatus, infraspinatus causes external rotation, but you've got a whole host of muscles on your back of the muscle which will do that. But what they should do really is activate early. They should do the initial thing. Even more importantly, on the supraspinatus. Supraspinatus is coming through that very narrow little space here on the acromion. Here we have a supraspinatus. What that does is, yes, it aids in abduction, but what it does is it initiates abduction. It does no more than that. It initiates it up to the first 20 degrees. So what it's doing is it's actually pulling here and actually rotating this in here. Now, unfortunately, this solid muscle doesn't let me show it. But if I look, there's a little golf tee and there's the big golf ball, okay? The supraspinatus, which is coming along the top of here, what that will do is that will initiate abduction. So it'll pull on the top and this will actually roll down a bit and come up like that, okay? If it's not working properly, or it's just the deltoids lifting up this arm, what that will do is that will lift it up here. And if those rotator cuff muscles aren't strong enough and working, they're not holding this in that little golf ball. So that is happening. And guess what's up here? Your acromion. Bang. Problem straight away. So always remember this. Manifests itself, pain, weakness, elevation, external rotation, due to excessive load on the rotator cuff tissues. We can test for this. We've got all these different tests. The problem with a lot of the shoulder tests is the specificity of them, and they're not probably quite as accurate. They're not probably quite as diagnostic as we'd like them to be. But we can roughly tell that with a supraspinatus, so we do the Hawkins-Kennedy, If we get pain on there, we can look at that. Empty can will tell us more of a bursitis. We've got the anterior jaw, the posterior jaw, that'll tell us about a rotator cuff capacity for holding it in compression. The sulcus test, pulling it down. All these things are very important, and do all these tests, but don't just rely totally on one being positive, saying that is the problem, because it's usually a combination of things that are going on. As I say, these tests don't totally correlate. So what we're going to do is treatment. What we're going to do is we're going to modify painful activities. We're going to use exercise, exercise which doesn't exacerbate the pain. We want to do a very important to do a controlled loading program, building up till you get to very complex loading and complex movements, and that's stuff which we all know about. That's what we're all doing, but we want to speed this whole thing up. And how do we do that? Well, that is use this MLS laser, fantastic piece of equipment, and we're going to start looking at that now. Right, what I'm going to do is I'm just going to go straight on to show you the control panel on the and hopefully this will be okay. I must have knocked this a little bit. Right, you can see that roughly, hopefully, and there's not too much problems on here. What we've got here, the laser, when we start it, right, we bring up the system, the body here. We're looking at the shoulder, okay? I'm going to go straight on the shoulder there. It's got a whole host of different pathologies which are involved in here. But as I said to you earlier, what we're going to do is we're going to actually go the global approach, and we're actually going to use a scan on these tissues. So we're actually not going to do the pathology setting first. We're going to go straight on a scan, okay? Now, again, it comes up two areas, acute or chronic. Generally, with a lot of the patients you'll be seeing, you'll be thinking more chronic. But you've had the fellow who's just come in, rugby injury, just smashed his shoulder down there. We can look at acute. It makes a difference because you'll see in more acute areas, what we're doing is the hertz are lower, okay? Here you can probably see 300 hertz, 6 minutes, 25% intensity. So the intensity is not up too much. If we start going chronic, okay, the hertz are coming up, 500 hertz, still the same time, but the intensity is increased. And in chronic stuff, this is where you want to go. So always keep that in mind. The more chronic something is, the higher the hertz we're probably going to go. Right, what it's doing here on the scan, it gives you the joules, 154.980 joules in total. It doesn't give you joules per square centimeter because it can't, because we're scanning around all these areas. And as I say, this is just a general guide. It's not saying exactly where you've got to go, but just really work on all the muscles that are around here. The anterior deltoid, we're going even into the arm. The pectorals, very important. People often forget about the pectorals, and the pectorals are so important because they're often a big problem with the position of the shoulder blade because the pec minor joins onto the coracoid process, which is that little sticky up bit on the front of the shoulder blade. And if that is tight as hell, it's just pulling the shoulder blade up and forward, and it's pulling that acromion therefore forward, which will cause problems on the supraspinatus and the probably biceps tendon. Actually, I'll tell you what, can I just quickly stop here because I'm going to come back and show you here. It's so much easier to show you in... Here's our shoulder. Okay, most people who come with shoulder pain will have literally... they'll have a massive postural problem. Now, why is that so important? The only thing that joins this thing on the body, on the trunk, is actually this thing, which is your clavicle. Comes into there, into the AC joint, okay? That joins onto the trunk, and this joins onto the acromion there. Now, if you can look here, acromion, you can probably see that only less than a third of the humeral head is actually in front of that acromion. That's where it should be, okay? Most people you see, if you look down at the thumbs, they'll be pointing inwards, they're internally rotated like that. And then we talked about the pec minor joining onto this coracoid process here, pulling that forward, okay, and winging scapula. Now look what's happened to that little space, okay? And that little space, bang, bang, bang. So it doesn't matter how much work and how much rehab and how much pain reduction we do, or the surgeon sticks the corticosteroid in there, it's not going to sort anything out. So what is so important is the posture. Just bring the shoulder back and control that scapula with the mid-traps. And look what happens to that space straight away. And then we can get in there with our laser and actually work so well to actually reduce the problems that we've got going on. Okay, let's go back to my little screen here. Okay, right. On the scan, it doesn't give you any joules per square centimetre. I just come across here, small, medium and large, everybody's medium unless Martin Johnson walks in the room or it's a tiny person, okay? Phototype A or B. White, Mediterranean colour, Asian, black. It makes a difference on the settings, as you'll see here. So if we just go across onto B, from A, white person, 506 minutes, 75%, black person, it's a longer time, less intensity. It's all to do with how the skin, the different colors of skin will take in the light, okay? So we've got a white person we're dealing on here. Let's just have a quick look at a lot of these little things and see what the settings are. If we have, sorry, get off here. It's a bit problem with the camera there. Right. Okay, if we went on to the pathology setting afterwards, bursitis, very important to use the optical window and actually try and get in there. But when we do, what we got is 900 hertz, 10 minutes, 100% intensity, so it's really quite high, 14 points. So we're just going to go right around there. But what it does here, it gives you joules per square centimetre, because we've got this head static, which we can do with the MLS system where we don't cook the person. And we can actually get the intensity on a set area so we know exactly how much power we're putting on a certain area. And what the machine does, it stops after each little intervention, goes to 13, and you move your handpiece and put it on the next one, and so on until it gets to 0, okay? A contusion, different 700 hertz, 4 minutes, 50%, 5 points. You'll see some of these are quite similar, but hematoma, more fluidy tissues, it's actually the hertz have gone right up, which helps with mechanical activity, so to try and move the fluids along. 5 minutes, 50%, 5 points. Muscular contraction, muscle tear. Again, we've got an ongoing tear here, more watery tissues, 1500 hertz. It's all set up for you, 5 minutes, 50%, 6 points. Right, these are the ones which we're going to be using most. Rotator cuff tear, you see, so 900 hertz, 10 minutes, 100%, so maximum power, 14 points. Again, I think this one's exactly the same. Yes, it is. So really, those are the ones which we're looking at, and they're probably going to be the most important ones we'll look at. Shoulder dislocation is more of a traumatic thing, more acute, so you can see the hertz are slightly lower. 8 minutes, 50% intensity is down a little bit, 7 points. Shoulder tendonitis, look, what are we going to use that on? That's probably more for your biceps brachii tendonitis. Again, it gives you points to go around here. We can use some of these, but you don't just go naturally just everywhere it says here exactly. Just think what you're treating and treat the tissue that you're on. Okay, so you can see all these things, different settings. It's all set out for you. If you've just got this, the NPHI, you won't have this little sign in there showing the handset. I'll show you what that's about later, because what we can do is with the Charlie, well, I'll show you now just quickly, we can actually set the Charlie head, completely different parameters if we want, and have the two things working at exactly the same time. But let's just get back onto here. Right, let's start treating our patient. I'm not going to go through, we can get our patient over here. I'm not going to go through setting up all the investigations I would do, because let's say we've got a rotator cuff, tear here. Let's say probably supraspinatus, okay? So we're going to, time-wise, we're just going to go straight onto there. Right, so let me show you what we've got here. Let's get on to the patient. And the patient is nicely set down there, all ready for treatment. You'll see I've sat her in a chair, and I find this is often the best thing to do for the shoulder. Also, I've got the hand resting on the plinth, so that will allow some actually nice slidey movements where we can actually get some active movements going in that shoulder. First time probably wouldn't do the active movements, but as soon as we can, we'll start getting the active movements going. Okay, so what we're going to do is we're going to go straight back to this, and we've decided this patient has a rotator cuff tear, but first of all, we're going to scan this. Now, this patient, it's been a problem which is going on some time, and it's getting worse and worse. It's a typical chronic problem, okay? So we're going on the chronic thing here. If we wanted to put a bit more power in there, we could go up with the hertz, but I'm going to always leave it with what they recommend to start with. We can go up higher if we want. So you just press on the number, we go 600. You'll see it just comes up very slightly. We can go up to 800. Okay, it's very simple, it goes up a little bit more. We can put a bit more intensity to increase what's going on. Now you see it's really moving up. But no, we're back on here. What it gave us was, I think it was 500. Let's go, I can't remember what they gave us. Was it 75 or 50%? Scan, chronic, it was 75. Okay, right, all we have to do is, first of all, before we press anything, give the patient the glasses. Very important that the glasses are worn if you're ever using this thing, because infrared light cannot be seen. You'll see a red little mark where the LED is showing where it's going, but do not use this without the glass on, because they will damage your retina and could even cause blindness, okay? Right, we've got the glasses on and we press start, okay? And you'll see it's all ready to get going, but nothing's happening yet until I actually activate the hand piece. So I'm just now going to go across here to webcam 2. Okay, I'm going to walk through here. And here we've got our handpiece. You probably see on here a little button. We just press that and we'll actually activate this button. Activate the laser. Now, what I want to do is I want to scan all around here. I would actually probably have asked the patient to have just a bra, actually it's the wrong side, but we're going to do the other side. A bra strap, so we can actually probably bring that down underneath the shoulder, and we've got this totally free because we want to get around there. But we can still do this, no problems. Okay. What we're going to do is we're going to press the button here. Oh, have I gone?
I was going to say, sorry, Paul, you've vanished. I don't know where you've gone to.
You can hear me okay?
Yeah, I can hear you fine. But all your video capability seems to have disappeared temporarily.
Don't know what's happening. Let's get back. Let's press that. Right.
That's back on. Yeah.
Okay. Right. So what we seem to have done is I've lost the camera.
Yeah. Is it still plugged in?
Yeah, that's what I just checked. Okay, not too much of a problem because we don't need to. We can move this back. Yeah, no, that's not. It's all that's okay. Right, you can see on this one.
Aha.
What we'll do is we'll move this around here, and hopefully we can do it with this. Okay, can you see her shoulder there?
Yes.
Okay, how do I get rid of that little box on there? Have you got a little box in the way?
No, I can't.
Yeah, fine. Right, I'm sorry about this because this isn't quite as good as I'd like, but what we're going to do is we're going to have this, we're going to start on here, start that. You can probably see there is this laser light here coming through here. We're going to work on nice, slow, on all the tissues, infraspinatus. Okay, coming right into the shoulder, deltoids. We want to get onto the pec minor on the front, just there. And what we could, if the patient is not having any pain, just starting a little bit of movement in and out as we're doing this. Now this will go on for as long as it said, which is 4 minutes. We're going to run out of time, so I want to stop this. So I'm just going to stop it here. But it would just naturally stop itself. Okay, it would just naturally stop itself. And then we have to come back onto here. Oh dear, this is... Right, so we can get back onto there. Oh dearie me. Right, if we just normally stop itself, what we'll do now is we'll just stop it ourselves. What we're going to do is we're going to pick the rotator cuff off that, rotator cuff tear. Again, if I can get this roughly a bit squarer, it's giving it everything we want here. 900 hertz, 10 minutes, 100%, 14 points. Again, I just press start again. Okay, and I'm going to come up here onto the patient. Can you see that?
Yes.
And we're going to treat now, again, just round into the area which is causing the problem. So I'm just not moving this now. I've got this in the area which I'm going to treat. I'm going to treat all these areas around the rotator cuff muscles, all the muscles which are coming into it. And I just want to wait for the first one because what it will do is it will just stop itself automatically. And I can do that and probably, I've got it on there. You can probably see on here, it's counting it down and it's gone to 13 now. So we're just going to move that to the next point and start again, and it will start again.
So Paul,
We'll keep on doing this till it gets down to 0. And then you've done your treatment. Okay? So I'm just going to bring this, I'm going to stop it myself. And I'm going to stop this bit. Okay, right, now let's come back here and let's see if we can hold this still enough for you. Well, I'm going to try and hold that as still as I can. There's a very important little thing on here, which is the trigger points. Okay, now I get up here, back on my shoulder. Trigger points. Okay, now I'm going to put it on the trigger point setting. I'm going to leave it acute. You'll probably see it's come up as 100 hertz, 20 seconds, and 25%. Okay, now let me just stop here for a second because I want to show you something else. What are we on about trigger points? Okay, I can get this back to. Right, take that off. The trigger points, massively important to deal with these because these are huge problems which cause pain, often even down the arm, and you'll get GPs mistaking them for some cervico-radiculopathy, which it really isn't. And it's just a major contributor to the problem we've got with the shoulder. So we want to treat these trigger points at the same time. Now, let me just show you the ones which we're particularly concerned about. Let's go to the infraspinatus. Okay, infraspinatus. Right, hopefully you can see this one here. Usually 3 trigger points in the, up to 3 or 4, could be more, in that infraspinatus region. You palpate them, you'll get a taut band, you'll get a twitch response, and you'll get pain coming down either, well, both sides, the back of the shoulder and the front of the shoulder, even a little bit in the interscapular region, and you can even get some tingling in the hands, okay? That is a big problem. If we look at levator scapula now, if I can. Levator scapula, another one. Know your trigger points, and you probably see here, usually just on the superior angle of the shoulder blade. Usually in this area here, these muscles are so involved in the neck as well, but coming down the inside of the scapula and across here into the shoulder. Right, I've also put on the deltoid, which is often one which is a big contributor to problems here. I won't show you both, but deltoid. You've got an anterior and a posterior deltoid. Let's have a look at the posterior deltoid. Sorry, it's the anterior deltoid. Again, problems here, cause problems right in the shoulder, real bad pain. And this is what a trigger point is where part of the muscle is stuck in a contraction. So you're getting a massive buildup of waste products, which then go on and cause further pain. And often one pain covers up another to a certain extent, you know, really what is causing the problem. So always deal with all these things at the same time. So what I'm going to do here is I'm just going to go back and I'm going to, if my equipment works here, I'm going to go back to the other camera. Right. Okay, get my glasses on. Right, now, if you remember, what I did was I set this on a trigger point setting, okay? It comes up automatically as acute. You could put it chronic, but these are, they're an acute phenomenon. So leave it on the acute, and then literally just press start. So what we're going to do is press start. Move this around to here. Right, now what I said to you was the big problem one is usually the infraspinatus. Let's try and get a bit more focus. Right, what we do is we'll get in here and we will just feel around. A little bit tender there, but hang on, I'm going to talk down here. Okay, if I press on there, and that. Right, just down here. Does that cause some pain in the arm?
Yes.
And down the arm. Right, so she's got an active myofascial trigger point in there. What we're going to do is, we've already set this up. We are literally going to get back on that area, and we're going to press on there and keep it stuck in that area. And this will go on for 20 seconds and it will automatically stop and we'll retest. Stops itself. Okay, let's get in here. I'm pressing really hard there. Is that as bad as it was? No. Look, this is almost magical how this works. But we have actually, just in one little go, probably we do 2 or 3 of them, and we'll look for other trigger points. 20 seconds a shot, and we actually get rid of the pain instantly. Just leave that going there. Okay, and so on. So we're in here. Right, I'm pressing really bloody hard there. Is that causing the problem? No. No. Right. There we go. Okay, I'm afraid equipment is not all working, but if we get back here, right, there we have it. It's 1:24. We haven't got any time to go on. There's so much more we could talk about, so much more we could do, but with this phenomenal piece of equipment, you can probably see just what we did there, how amazing the changes can be so rapidly. So over to you, Phoebe. Have you got any questions for me?
Yes, there's a couple of questions. Someone said, you mentioned previously that manufacturers like to use 10 hertz, 23 seconds, 50% intensity for acute conditions. Yeah. Which replaces the machine's 100 hertz, 20 seconds, 25%. I'm not quite sure what the question is there.
What it is when you put up the trigger point setting, working on a trigger point, which is a true trigger point. Now, true trigger point is where the some of the sarcomeres are actually stuck in a contraction because the neurotransmitter acetylcholine has got stuck in the blocked in the motor end plate. So it's actually stuck in there, and you get in a buildup of waste products, and you have these trigger points. Now, what that question was relating to is, when I spoke to people before, I was told by the ASA people that if you get, instead of it just not naturally a trigger point, but if you have some point which is just incredibly painful, and I'm talking more about a tender point than a trigger point, but you could try it on a trigger point. I wouldn't. I'd use a setting we give us for trigger points, but in really, really amazingly tender points, really sore areas you've got, if you actually change that hertz to 10 hertz, and you actually almost see it flash when it's on, because it's, you know, there's only 10 hertz a second. You go up to 23 seconds and just increase the intensity slightly, probably up to 50%. And it has a bit like I did on that trigger point, where we lost that trigger point in after 20 seconds. But you can actually get on these really tender points and get pressing on them and push on them. And you'll find that the people saying, well, the pain's not there. What have you done to me? I've just done a little trick. But that's what it's doing. On an ultra acute tender point, you can actually change that to 10 hertz, go 23 seconds, and just increase the intensity very slightly.
Thank you very much. Someone else asked, when you're using the laser on a trigger point, are you applying pressure with the head of the laser, or are you literally just applying it to the skin? Trigger point.
I don't even make much difference. What because I like messing around a bit, I just give a little bit of pressure on there, and I just, without moving the thing, but on the skin, I just give a very slight little circular movement. It's a personal choice, really. That's what I do, and it just works.
Thank you. Someone else has asked, are there any contraindications to using the laser? I know you spoke about it a little bit last week.
Yeah, there are contraindications in an active cancer. If somebody's in remission, we have no problem. If it's an active cancer, just don't use the laser because it's stimulating at a cellular level the cells. And if we've got rapidly dividing tissue, we don't want to do that. The point is, they might have, I don't know, they might have a throat cancer and we're sorting out their foot. No, just don't do it because of legal repercussions which could come. No, I just don't touch anybody with cancer. Pregnant people, fetus, rapidly dividing tissue, we don't want to speed that up for obvious reasons. I said something last week which my wife really went mad with me afterwards. So I won't repeat it this time. But my point is this: we do not over something where we have rapidly dividing tissue. We don't speed that up. Now, one other area where we've got to be really careful is on growth plates on children. And the reason for that is the growth plates, if we're stimulating the cellular activity there is theoretical, lots of literature theoretically that this could actually stimulate the growth plate to feeling that it's ready and that's finished. And so you get, as I say, little Johnny with one leg longer than the other. We just don't do that. But you can use it on other parts, you know, it's just don't use it directly on the long growth plates, the long bones in the lower limb.
Thank you very much.
Don't use it, otherwise don't use it over a pacemaker. On that basis, I try not to use it on somebody with a pacemaker if I'm doing their foot or something, but you certainly don't put it on the pacemaker because you don't want to disrupt that. But apart from that, it's just an incredibly safe machine. Use it over prostheses, you know, hip joints, metal structures. Yeah, it's fine. Absolutely good.
Brilliant. Someone else just asked, when you change on the display now, if you change the value to chronic trigger, the value on the machine changes. So obviously it's preset, isn't it?
Yeah, it'll change again. It'll in the chronic, I imagine it's going to probably go up to about 3. I'll check if you want, but it'll probably go up to about 300 hertz or something like that. And we want to keep these hertz lower in this acute. The research they've done at ASA is pretty good, and they know the settings that we have here are generally right. So I try not to mess around with them. What I do for people who want to know, if we're using a setting, in a chronic situation and we haven't had any change after the first time, I'll probably put a bit more intensity and probably increase the hertz slightly. There is something which I didn't go on this week, but we can actually whack the joules which are delivered up hugely. But you don't always want to do that because you can get a rebound effect where you're putting too much energy into the person, and they'll sort of complain the next day, say, I felt a bit worse. Usually with a rebound effect, within 48 hours, they'll be back to where they were. But just, if you, like anything we do, if we're rehabbing somebody, we gradually increase range of movement. We gradually do anything. Tissues adapt to stress as you put them under. If you stress them too much, they're going to fail with rehab. If you put too much power in there in the initial stage, it's not going to be very happy. So build up, and then you can build up and use whatever you want at the end.
Brilliant.
The important thing is go from feedback from the patient, and if you just gradually go up, ask them, find out. They want their report back. How are you feeling? Any improvement? We put the power up a little bit last week. Has it made any difference? Yeah, it's good. Or no, it's not good. Okay.
Thank you. What about using laser for neurological events? So I post AVM rupture.
Sorry, after what?
After an AVM rupture.
Just neurological, superficial neurological stuff, peripheral neuropathy, absolutely perfect. Does very good results. Diabetic neuropathy. I personally haven't. With somebody, you could have neurology, you could have stroke, X-stroke. Yeah, it's fine. Use it, because this is where we can actually just, they'll have so much time, so much contractures, so much problems like that. Yes, use it. There's no problem there at all.
Thank you. And someone else asked, will the patient feel anything during the treatment?
No, generally, no, they won't. There is a chance they might get, depending on what your settings are, they could possibly get a tiny bit of topical warmth. But no, they shouldn't feel anything, because the way the machine is calibrated, that's the beauty of it. It's sending in so much power, but on the 905 nanometers at 25 watts, it's super pulse at a nanosecond. So it's on for a nanosecond, off, on, off, on, off. The tissues heat, cool, heat, cool. So what they do, if you left that on the highest power for 15, 20 minutes, I think the research has shown you could get up to 42 degrees centigrade. There is certainly a bit of warmth coming in there, but not enough for you to generally feel. If it was 42 degrees, yes, you would feel it. But generally, our treatments aren't as long as that. But it will never get to where we're causing over 43 degrees. That's where we're starting causing tissue damage. And 45, that's where the tissue damage really begins. And it won't go there.
Great. How many times a week could you use the laser if you...
You could use it every day if you wanted. It's not possible, with the general working population to be able to do that. So what we have, a recommendation is 3, 2, 1, okay? Try and get the person, especially in a more acute situation, 3 times in the first week, twice in the second week, once in the third week, and then continue once a week after that. And this is where you're going to get the effects, because the effect of this machine is cumulative. If we just start off and just do once a week, we're probably missing a bit. To get the thing really going, try and get it 3 times the first week, twice the second week, and 1, and then we can do the continuation going forward. But by doing 3, 2, 1, we really have a massive effect, massive change straight away.